course, which we'll be announcing very soon. So now over to Dr. Lipika for the topic Kickstart to Reproductive Immunology. And before that, I would like to introduce Dr. Lipika. Dr. Lipika has been our a very esteemed faculty member with the Fertility Academy. And if I there's a lot to say about her, but I'll just say a few things because of paucity of time. Ma'am was the best MBBS graduate and state topper, and she got honors and gold medals in Obs and Gynae during her MD exams. She has also done a fellowship in reproductive medicine, clinical embryology, and ultrasound in subfertility and PCOS. Ma'am has a diploma in sexual medicine and subfertility. She has a diploma in laser and cosmetic gynecology. We'll be very soon starting a course on cosmetic gynecology, which will be conducted by Dr. Lipika and her husband. Sir is also a very renowned dermatologist from Eastern India. And she has been conducting India's first dedicated full day workshop on PCOS, first of its kind. He's a trainer in immunology, sexual medicine, infertility, IVF. Ma'am is also a member of SR Youth Brigade, and she has been part of SIG Infertility and NCD, and she's a member of National SR Sexual Medicine Committee, and she's the Eastern Zone Coordinator for Foxy Young Talent Promotion, and member of Foxy Sexual Medicine, Foxy Endocrinology Committee. She's a managing director of PCOS Society of India. She has been awarded the ISAR Youth Icon Award in 2023 and 24. And she has got numerous publications on PCOS and other interests of her choice. And ma'am is also a very active member of IMA Odisha chapter, where she was a joint secretary for the Cuttack branch. And she's an invited faculty in most of the national and international conferences happening in Southeast Asia. And she has got a special interest in PCOS, genetics, male subfertility, and sexual health. Ma'am has been a trainer with Fertilis and Sadbhavna Academy, and is also an editor in a national IVF newsletter. And ma'am is now serving as the clinical director of She Care Aesthetics and a consultant in fertility, sexual medicine, and PCOS at the Arogyam Clinic and Origin Fertility Center. So over to you, ma'am. I would like to end the presentation now. Thank you so much, and over to you. I'm stopping the screen share, and you can take over, please.
Thank you so much, sir, for your kind words. So I'll just share my screen. It's good to see so many delegates attending the demo class because this is a very unique one of its kind course which sir has taken the initiative, and this is the third edition of the course that we'll be doing. We'll be starting from 22nd of May. So I think just few things which I would like to, is my screen clear, sir? And my voice as well?
Please,
Or should I be louder?
make it full screen, please. So it will be better.
Done, sir. Is it clear now?
Yeah, everything is clear. Just make the
Okay.
screen full screen. Just make it full screen.
Yes, sir, I've done full screen already. Is
No,
it visible?
it is visible, but I don't think it's full screen. Just move the slide.
So I think it's full screen now.
No, now it is full screen, I think.
Yeah.
Now it is full screen.
So I think sir has told about how unique this topic is, and it's very challenging, very complex. But being a reproductive endocrinologist and into this field of infertility, we see innumerable cases in the OPD. Every infertility case does not just need an IVF, so we have easier methods to approach those cases. So I would just request all of you to be very attentive throughout the session. So you can just note down your questions or you can type it in the chat box. So we can take the questions at the end of the session. So
Sorry
what
to
will be,
interrupt, Dr. Lipika. Sorry to interrupt. It's still not full screen, I think. You have to press on the the icon down there. I mean, or you
yes,
through
I've done it full screen because it's looking full screen
you
on
go
my
to
side.
view. It is okay, but it's not showing full screen in our.
Just a minute, sir. Then I'll
You can
stop
just
share.
shut it down and shut down and
I'll stop share and do it again, sir.
please.
Is it full screen now, sir?
It's still not showing up on our screens. Just
But it's showing
yeah.
on my side. Now it's not full screen, but I make it full screen now. From
Okay.
my side, it's full screen.
Okay. Then I think you can start then.
Yeah, but can any one of you in the any of the doctors can you tell me is it full screen for you?
Is it okay with the audience, with the delegates? Can you see clearly?
It is not full screen, ma'am.
I'm surprised, but I'm doing it full screen anyway.
Dr. Lipika, there is a view on the taskbar. There is a view. It's written view below the search window. On the top screen, taskbar, there is an icon by the name of view. Can you see that?
No, sir.
Top home, then insert, draw, design, transitions, and then
Okay,
there
yes.
is view. You
Yes,
click
sir.
on view. Click on view.
Just a minute, sir. Actually, this Zoom taskbar is also popping in at the same time. I'll
No,
just,
you can just keep it one side and
just a minute. Yeah. Yes, view I can see.
you tap on view.
Yeah.
Now, no, it's uh,
Oh, the full screen thing is on the bottom only, sir. Here, this one. This
yeah.
one?
Just click on this.
Yeah.
Click on this. Yeah.
That's what I was clicking. It's full screen now on my side, but I'm surprised how it's not coming.
Ma'am, you
Somebody
can try F5.
F5. Yeah,
Just
F5.
a
You
minute.
try.
Just a minute. Is it full screen for you all now?
No, I think there is where you are clicking on the bottom. There is it's showing 55%. Maybe you can just increase it to 100%.
Yeah, might be. Yes.
Increase it to
No
100% or
problem.
yeah. But now it is cut. The
Now,
slides are getting cut.
is it okay now?
No, it's not increased. Make it around 80% then. Make it around 80%. Uh,
Is it okay now? But for
70%
us,
maybe. Yeah.
completely full screen, I'm surprised. Just let me see, sir. 1 minute. Because if it's not full screen, lot of images are there. It won't be clear for the doctors attending. It's okay. Like we'll start.
If you can, if it's a light file, you can just share with me.
Sir, if it's is
I
it
can play
visible
the.
now, sir?
Yeah, it's visible. If you send it to me, I can play it from my side.
Okay. But then, sir, you will have to be there all through to
No
change the
problem.
slide.
No problem. No problem.
Okay, sir. Okay. I'll just do it.
If you WhatsApp it to me, I can download and share.
Just a minute, sir.
Just be patient. It will be taken care in a minute.
I've shared, sir.
On WhatsApp?
Yes, sir. Okay, so in the meantime, while it gets, sir, I should stop shares now so that you can share the screen.
But I have not received your.
It's just going, sir. It's a
Link.
big file, that's why maybe. It's gone now. Have you received, sir?
Just give me 1 second here. Yeah, I've received it now. I'm just playing it. Give me one
So
second.
I'm just trying for the last time, sir, if it, in case it
Yeah.
happens. Is
Please.
it visible, sir, full screen now? Because it's full screen on my side. I'm surprised why it's not happening. It's still not full screen?
Uh, I think it is now full screen. We can ask the participants.
Can any of the doctors tell us? Is it full screen now?
Yes, ma'am.
Yes,
Okay,
full
sir. Thank
screen.
you so much. Thank you. Otherwise, sir would have been bothered unnecessarily
No,
throughout the time.
not at all. Not at all.
Okay. So I would just like to tell you this is a very, very complex subject. Even for me also, when I started this topic, when I started having patients and I learned about this topic, it was very complex because I think all of us will agree that we don't remember immunology. What is an MHC molecule? What is CD4? What is CD8? What is a helper T cell? We are not aware of that. And without understanding the basic physiology, it will be very, very difficult. There are two ways of approaching a case. Like we can go clinically and straight approach the case history taking test and then we give the treatment modality, or you understand the basic physiology so that you make the patient invest the minimum and get the maximum results out of it. So basically today's talk I'll be covering four aspects. Like first we'll have a difference between RPL and RIF because lot of us confuse between recurrent pregnancy loss and recurrent implantation failure. So my first few slides will be on that. Then I'll cover some basic aspects of clinical immunology where you'll get to hear about B cell, T cell, what are CD markers, what are NK cells, how are they important, how do cytokines affect our body and all of that. And then you have immunology of pregnancy, like what happens in normal pregnancy, and a small few slides on implantation, like how does implantation happen. If you don't understand that, you will never understand why implantation failure occurs. And then the last segment will be on why certain pregnancies implantation failure happens, why they fail to implant. You get two lines on the biochemical on the pregnancy test kit, and then it becomes one line and the patient has bleeding. So why does that happen? Or she has a single line from the beginning. So why do implantation failures happen in certain cases? And I'll just give you a perspective of what you need to do. What was my purpose for doing this demo class was that I just want you to think in lines of reproductive immunology. In a case where you have investigated a recurrent pregnancy loss for all the obvious aspects like anatomical abnormalities, coagulopathy, genetic karyotyping abnormalities in the conceptus or in the parents, and you're not getting any cause. That is where you think in lines of immunology. So again, it is a hit and trial method. There is no guarantee in things, but always, if immunology works, if something works, it means that the failure of that will result in implantation failure. Okay. So I'll start with something which was very, very interesting. And this is always my first slide in wherever, whatever places I give talks on immunology, this is always my first slide. So no doctor has ever healed anyone of anything in the history of world. The human immune system heals, and that is the only thing that heals. So it is that much important. So we have to think in lines of reproductive immunology. So I've told you about this. What we shall be covering today, RPL versus RIF, diving into the basics of clinical immunology, introducing reproductive immunology, understanding implantation, just few slides on that, immunology of normal pregnancy, and immune imbalance leading to implantation failure. Okay. So what I mean to say is be very, very attentive, because I'll not be reading out the slides. I'll only be focusing on what is very, very important, and few slides I'll skip because of the complexities, and we'll later on cover those details when we go for the detailed course. Okay. So this is one thing which you all need to print in your minds. All recurrent implantation failure cases are recurrent pregnancy losses, but all RPL cases, all pregnancy losses are not implantation failure cases. The second thing is recurrent pregnancy loss can occur at any gestational age, but RIF cases, that is implantation failures, are only early or very early pregnancy losses. Okay. So we start the first segment, that is RPL versus RIF. I will take a pause after every segment so that you can ask your question which is pertinent to that segment, and then we move forward. Okay. So recurrent pregnancy loss affects a huge burden of couples planning for pregnancy, which is around 2 to 5% of general population. However, around 10% of all couples undergoing IVF treatment can have this problem. What is very distressing about this condition is that nearly 50% of couples are not aware as to what is happening to them. They are conceiving spontaneously, they are readily conceiving whenever they are planning to conceive, but they're not continuing their pregnancy. So what is going wrong in their case? Again, which adds to the complexity of this condition is the heterogeneity. There is confusion in every segment of this problem. It can affect any age group. So a young couple coming to you, you normally do not expect an implantation failure, but also they can have implantation failures. And it is one of the most frustrating and challenging conditions in reproductive medicine. The diagnostic and therapeutic modalities are again not always reliable. When we move ahead with the course, if you register in case for the whole course, you will come to know that whether it's the diagnostic modalities, whether it's a treatment modalities, I'll always tell you there is no documented evidence. Whatever large-scale studies, RCTs, although very few RCTs and meta-analysis have been done, whatever few studies are there, they are also confused. Like always the last line of all studies in immunology is that there is inconclusive evidence regarding this treatment modality. So it is always that you try for your patient. If it works for you, believe that it works. It's like that. Okay. And whatever studies are there, they are all flawed, because either the subject population is not catering to your side of population, or the therapeutic modality is not matching with what we plan to use for our patients. Okay. So the heterogeneity and ambiguity, the confusion begins from the very definition. So, what is an established pregnancy? Then only you can think of recurrent pregnancy loss. So a pregnancy is classified as a clinical pregnancy recorded by ultrasound or by histopathological examination after miscarriage, or both of these. So this is the only defined definition for a clinical established pregnancy. But you can also take, I'll come to that. That's again a huge topic, biochemical pregnancies. I'll come to that. So nowadays, biochemical pregnancies are also considered as established pregnancies. Okay. So as far the big societies of gynecology are concerned, ASRM and ESHRE, both of the societies are still, they have controversies in the definition of pregnancy losses. ASRM claims that two or more than two miscarriages can be defined as recurrent pregnancy loss, whereas ESHRE says that three or more miscarriages should be defined as recurrent pregnancy loss. So this we all know that with every subsequent pregnancy loss, there is an increased chance of losing another pregnancy. So it increases with age. It also increases with the number of miscarriages that the couple has encountered. Now, these were some classifications of RPL. So there are three types of ways in which RPLs are classified. One is primary RPL, secondary RPL, and tertiary RPL. So on which parameter this is based? This is based on previous live births. So for a primary RPL, a woman who has lost two or more pregnancies in a row, but no further than 20 weeks. So no pregnancy has continued beyond 20 weeks. That is a primary RPL. She has never had a live birth. What is secondary RPL? She has lost two or three pregnancies after a pregnancy which has crossed 20 weeks. So that might have resulted in a stillbirth or a miscarriage beyond 20 weeks or a live birth. Now, what is tertiary RPL? They have suffered multiple pregnancy losses prior to a pregnancy that went past 20 weeks. Again, there was miscarriages. So first miscarriages, then a beyond 20-week pregnancy, and then again a set of miscarriages. That is what is tertiary RPL. So I've just put the same thing in a table manner to make things more simplified for you. You can take a picture of this. So this is how RPL is classified according to the number of pregnancies which has crossed 20 weeks, primary, secondary, and tertiary. Now we move on to causes. This is probably the most important one which is relevant to clinical practice. So based on etiology, how do you classify RPL? So there can be known etiologies like your septate uterus, some genetic abnormality in the conceptus, which is very obvious causes. So there you find a definite cause and then you work on solving it. The other category is an unknown category. For the unexplained RPL, you again have two types. This is very, very important. So unexplained RPLs can be of two types. One is type 1, one is type 2. So in type 1s, it happens to older women with less than 3 miscarriages. This includes biochemical pregnancy, and usually the cause is a genetic aberration in the conceptus. So most often in type 1 unexplained RPL, you often find some genetic abnormality. In type 2 unexplained RPL, it happens with younger women and the cause often remains unidentifiable. So this is where our focus is in the cases of reproductive immunology. Okay, so how do we think in the line of immunology is only after ruling out obvious causes of recurrent pregnancy losses. Okay, and always remember that even with a known cause, immunological cause can still coexist. So what I do for my patients of RPL is that when I find an obvious cause, say for example, I found say coagulopathy, okay, I'll work on that. I'll give some low molecular weight heparin, I'll give ecosprin, whatever, and along with that, I also add immunomodulators, okay. So I cover her from all sides so that pregnancy she again doesn't end up losing the pregnancy. All right. So what we are working on is type 2 unexplained RPL. You can note that. Note that down on a copy. Okay. At the end of this talk, you should be noting down at least 10-15 take-home points. So this is how I've just tabulated that, the same thing, type 1 unexplained and type 2 unexplained. So this is again a very important, this is a very good photo wherein you can see that 50% of cases of recurrent miscarriage, you can identify a cause and you can explain the patient. But in another 50%, it is completely idiopathic. So this is what we are working on. And out of this, you can see the left side is the unknown causes. And out of that, alloimmune rejection is just one of the cause. So we are focusing only on this alloimmune rejection in this case for this course. Okay. So you can see if we list common causes of recurrent pregnancy loss, genetic disorders, immunological disorders, alterations in the uterine cavity, and coagulopathies. So there are 4 common main causes. Okay, so out of that, you can understand if we list top 4 causes of pregnancy losses, immunological causes among them. Now, this is again the causes of recurrent implantation failure. You can see there are so many causes of recurrent implantation failure. Out of that, again, one of this is the immunological factors, which we are going to discuss in this course. Okay. This is a good tabulated form of the causes of recurrent pregnancy loss, but we are not discussing this. We are only concerned with the early or very early recurrent pregnancy losses, wherein the cause is very likely to be the immunological cause. Okay, this is a flowchart for working up a case of recurrent pregnancy loss. This is beyond the purview of this course, but I have just listed it so that you understand. I've just told you a few minutes back that an immunological cause can always coexist with other cause. So therefore, you always go through this flowchart, work out accordingly, and then identify an immunological cause if you think so. Okay. This is a good table which shows us the RPL causes, diagnostic test, and potential treatments. And this is again for patients, especially for patients who are going for IVF. IVF cycles have increased in geometric rate, in geometric progression these days. So therefore, I've included embryo, male factors, the protocols of IVF which I used. And ultimately, it is all about individualization of the patient. No couple is same, no husband is same, no wife is same, right? So we have to work up accordingly because one size does not fit all, right? So now I come to the last aspect of the first segment. How often have we encountered biochemical pregnancies? I think all of us will agree we see n number of cases landing up in biochemical pregnancies. It is very, very disheartening for the couple and for the clinician as well, wherein you find 2 lines on the kit, and then after 1 week she comes and says, I had bleeding, and then there is 1 line in the kit. Okay. So the big million-dollar question is whether you would include biochemical pregnancy in a pregnancy loss or you should not include, right? So biochemical, there is again lot of controversies regarding this. ASRM tells that pregnancies that can be recorded only through ultrasound or histopathology should be included under clinically relevant pregnancies, and the loss of such a pregnancy should be considered as pregnancy loss. So what ASRM claims is that we should not be including biochemical pregnancy loss as a pregnancy loss. But ESHRE says that any pregnancy which is confirmed by a positive beta HCG testing has a negative prognostic significance equal to that of a medical miscarriage. What does ESHRE mean by this? Because most of the couples, once they conceive, the first thing they go to is the pregnancy test kit. Okay, and that double line is confirmatory for them. Therefore, because most of the population tests the first test of pregnancy by that kit, so the strong clinical practice points as far as clinicians and ESHRE is concerned, we have to take biochemical pregnancy loss as a recurrent pregnancy loss case, right? Biochemical pregnancies make up as high as 37% of recorded pregnancies, and that each additional non-visualized pregnancy reduces the chance to have a live birth by 10%, which is huge. So if you are neglecting a biochemical pregnancy, you are neglecting the chance of a subsequent pregnancy loss by 10%, which is huge, right? So biochemical pregnancies is therefore to be considered as a pregnancy loss. So this was the first segment. Any doubt on this? This was very basic, so I don't think any doubts will be there on this. So is there any question in the chat box? Anyone has any question on this, RPL and RIF? Or I move to the next segment? We have a lot to cover. Okay, thank you so much. Thank you for replying. All right. So basics of clinical immunology. This is very, very complex. Pardon me if I'm not clear somewhere. You can ask me, but I've tried my best to make things as simple as possible, right? So we have to understand clinical immunology. Otherwise, you'll not be able to approach your patients in a proper manner. There will be n number of questions, right? So I start with a very basic. What is non-specific immunity and what is specific immunity? So we know there is some host defense mechanism wherein any organism can just not attack us and give us cold, cough, and whatever, any viral infection, bacterial infection, because we have some innate defenses in the system and some specific defenses, wherein if repeatedly the same microbe attacks us, then the adaptive defense mechanisms come to play. So out of that, what we will be dealing in the immunology courses, B cell and T cell mediated immunity. Okay. Now, innate and adaptive immunity, I'll not go into the details, but just remember that innate one is very mild, and therefore this is not the pregnancy which is protecting your pregnancy wholly. Okay. So adaptive immunity also comes into play at the end of the, like towards the end of the implantation phase. but it always begins with innate cells, because you can see there are innate cells. NK cells comes under innate defense system, okay? And NK cell plays a very, very big part in protecting your pregnancy in the early implantation stage, right? So these are very basic graphs you can go through later on. And these are the cells of the immune system. Like we have from a stem cell, you have myeloid progenitor cells and you have lymphoid cells. What we are dealing with in immunology is mostly the lymphoid cells. However, the macrophage dendritic cells are very, very potent cells which are playing a big part in immune system, in reproductive immunology, I'll tell you. And this NK cells, you can see I've put it in myeloid cell lineage as well. I've included it in the lymphoid cell as well. I'll tell you, the next photo will speak. Okay, see. Can you see here, this also has NK cells. So the lymphoid lineage has NK cell and the myeloid lineage also has NK cell. So we know that lymphoid cells can be B cell, T cell, and T cells can be memory T cell, cytotoxic T cell and helper T cell. Okay. B cells can be, we are all aware of plasma cells in humoral immunity and some memory B cells. Now CD markers, this is again something which is very important and creates a lot of confusion in our minds. What is CD4? What is CD8? So CD stands for cluster differentiation factors. Okay, there are basic CD markers for certain major group of cells. I just want you to remember this part which is marked in red. So basically all T lymphocytes will be CD45 plus, means that CD45 marker is present on the membrane, and CD3 plus. So all types of T, like T lymphocytes will have CD45 plus and CD3 plus. Helper T cell will additionally have CD4 plus. Cytotoxic T cell will additionally have CD8 plus. Okay, till here it's clear. B lymphocytes will have CD45 and they can either have CD19 or CD20. And natural killer cells are completely different. They will not have 45 or 3. They will have CD16 plus. Okay, CD16 plus and CD56 plus. Just keep a note of this, because sometimes it's not written NK cell. They will just write the cell in the form of the CD marker. If you're not aware that helper T cell is CD4, they'll write a CD4 T cell. You'll not be able to recognize that, okay, it's a helper T cell, right? So just remember what is marked in red, rest others is not important. Okay, B lymphocytes, I'll not spoil much time on this. This maturation occurs in the bone marrow, therefore it is called B cell. B lymphocytes. There are two types, plasma cells and memory B cell. Plasma cell, we are all very much aware that it produces antibodies. It is one plasma cell is capable of producing up to 1000 molecules of antibody per second. So that is how humoral immunity is maintained. But plasma cells do not have any membrane bound antibodies. They just release those antibodies into the circulation. Memory B cell, they have a membrane bound antibody. What do you mean by memory basically? So if a repeated pathogen is again attacking your immune system, this memory B cell is retained and that fights against the repeated pathogen. What is important to us? T lymphocytes. N number of times you will come across these T lymphocytes. So it is named after their site of formation, that is the thymus. T cell receptors only acknowledge antigens which have membrane bound to cell membrane proteins. So I'll tell you in simple way. You can just read out the slide for yourself. I'll tell you. So T cells will fight against the pathogen, but those pathogen needs to be processed and presented to the T cell by a protein which is called MHC or HLA. Okay. So major histocompatibility complex molecules or MHC molecules. They are basically cell membrane proteins which will present that processed antigen, that pathogen to the T cell. I hope I'm clear. So there are three classes of MHC molecules, class 1, class 2 and class 3, right? Now we'll just stick to T cells. Just see how I've labeled the types of T cell. One is helper T cell, one is cytotoxic T cell, one is regulatory T cell and one is TH helper T cell 17. Okay. So just remember just keep noting down important points. Helper T cell has CD4. I've shown you in that table of CD markers. Okay. Cytotoxic T cell has CD8 markers, right? And what is the ratio of helper T cell to cytotoxic T cell? It is 2:1. Okay. Now what are regulatory T cell? They are very, very potent immunoregulatory cells. Okay. They are immunosuppressive cell. So they are good for pregnancy. Just remember this in shortcut. So, regulatory T cells are immunosuppressive, immunoregulatory cells which are good for continuation of pregnancy. Okay. Helper T cell 17 is a bad cell. It is a pro-inflammatory cytokine kind of T cell which damages pregnancy. So, which causes miscarriage. All right. Now, I will make it simpler for you again. So, helper T cell has CD4. Cytotoxic T cell has CD8. Regulatory T cells are immunosuppressive cells and they help in continuation of pregnancy. Helper T cell 17 is inflammatory cell and it causes miscarriage. Okay. Now NK cells. So NK cells I've told you they have CD56 and CD16 markers. Again remember CD56 NK cells can be of two types. Alright. One is CD56 bright. One is CD56 dim, depending upon the concentration of the CD markers. So if they have more number of receptors on the CD markers, they appear as bright cells on the immunohistochemistry. Therefore, CD56 bright and CD56 dim. So as of now, just note down that CD56 dim cells are found in the peripheral blood, right? CD56 bright cells are found in the decidua, that is in the uterine endometrium. All right. So this is how we remember. Okay. Just remember CD dim cells in the peripheral blood can become cytotoxic. So remember that CD56 dim cells are cytotoxic. That is, they will destroy the pregnancy. CD56 bright cells are found in the endometrial lining and they are protective for pregnancy. Just certain tips. We cannot remember it all. So I've made it point-wise for you. Just remember what I'm telling. Okay. Now, what is MHC? I've told you. So basically, MHC are proteins. They are genes which produce proteins and they participate in the development of cell-mediated immune response. So I've told you already, class 1, it is present on all the surface cells of nucleated bodies. Class 2 is present on antigen-presenting cell. Just remember the last part of the slide. Last 3 lines of the slide, very, very important. Class 1 MHC molecule presents peptide antigens to CD8 cells. That is cytotoxic cells. Am I clear? I'll give you a formula for remembering this also. Class 2 MHC molecules will present processed pathogen to CD4 cells. Okay? Don't remember class 3 MHC. It's not required. Basically related to the complement cell of immunity. Okay, we're not going to talk about that, although that's very important. So just remember the formula that I was telling. So class 1 MHC, CD8 cell. Class 2 MHC, CD4 T cell. That is helper T cell. How do we remember that? 1 into 4, 1 into 8 is 8. 2 into 4 is 8. Am I clear? So class 1 MHC will represent the pathogen to CD8 cell or cytotoxic T cell. And class 2 MHC will represent the pathogen to class like CD4 or helper T cell. So 1 into 8 is 8, 2 into 4 is 8. Okay. Now just have a look at the right lower figure. Can you see this where I'm moving the cursor? So you can see this is a CD4 T cell. That is a helper T cell. Okay. This is the antigen presenting cell. So which are the two types of antigen presenting cell? From the myeloid lineage, I had focused on 2 cells. Which were those 2 cells? One is macrophage, one is dendritic cell. All right. So these are the antigen presenting cell. What they are doing? They are engulfing the pathogen which is attacking you. They are again processing that and presenting that to the T cells. Okay. So CD4 cell MHC2. Can you see this where I'm moving my cursor? Okay. And CD8 cell MHC1. Okay. All right. So I'll not go into this. You will be confused now, but this has clinical significance. I'll tell you later in the course about HLA-DQ alpha. All right. Now, what are cytokines? What are cytokines? They are simple set of proteins which are secreted from immunologically active cells. So just remember, wherever you hear interleukin 1, interleukin 2, interferon gamma, this, that, TNF alpha, lymphokines, interleukin 6, 3, 10, 1. So those are cytokines. They are a set of proteins which are released from immunologically competent cells. Okay. So when I say that a cell is pro-inflammatory, the cell is not pro-inflammatory. The cytokines which the cell produces, that is pro-inflammatory. Okay. For example, I told you TH17 is a bad cell. It is a pro-inflammatory cell which causes miscarriage. So what does that cell do? That releases pro-inflammatory cytokines. Okay. Am I clear? So you can see I've written at last 4 lines, you can see cytokines with helper T cell 1 response. So remember I for 1, I looks like 1. So just remember Th1 cells are inflammatory. They are bad. Okay. Helper T cells are of 2 types, 1 and 2. 1 is inflammatory, 2 is anti-inflammatory. Okay. So just remember 1 cytokines are inflammatory and they'll cause miscarriage. 2 cytokines are anti-inflammatory and they'll protect the pregnancy. So remember these cytokines, it will come often in all the slides, okay, which are pro-inflammatory and which are anti-inflammatory. So if there is a lot of anti-inflammatory cytokines, the pregnancy will continue. If there is an excess of pro-inflammatory cytokines, the pregnancy will abort. Right? So I've written here, loss of balance between helper T cell 1 and 2 responses can lead to alloimmune miscarriage, with Th1 responses being more than the Th2 responses. Alright? So lot of helper T cell 1 will produce inflammatory cytokines, the pregnancy will abort. Lot of anti-inflammatory cytokines, the pregnancy will continue. So this is what is being shown in this figure. Okay? So all of the figures are related to that only. So I think this is the basic of clinical immunology. Any doubts on this? See, you have to repeatedly see the recording of the lecture, because once this session is over, the recordings will be available on our Fertilis channel on the YouTube. So you can have a repeated viewing of the lecture, because it's not easy to understand it in one time, and I'm trying my level best. Any doubts on the basics of clinical immunology? Should I move further? Can someone write in the chat box, please? Okay. So I think, okay, thank you so much. That's a big compliment. All clear, ma'am. That's very gratifying to me. Thank you so much. So we'll start with introducing reproductive immunology. I will purposefully skip, like many slides, because one is we have to finish the lecture, and like I cannot finish it within a short time. But I will tell you all key points which will help you in, attending the further lectures once you register for this course. All right. So this is a very, very complex enigma. It's difficult to teach. It is difficult to learn. It is very confusing. So it's like a complex jigsaw puzzle kind of thing. You feel lost. But we'll only understand what is relevant to clinical part, right? So this is the complex feto-maternal interface where all of this immunological confusion happens. And pregnancy is a miracle. That's what all I have to say after I understood immunology. Things which are happening in a favor of a pregnancy, it's beyond imagination, right? So this is the feto-maternal interface, and this is the embryo implanting into the uterine endometrium, which is pregnant endometrium is called deciduum. Okay, so then you can see that, like the first line is very intriguing. How ma'am has written this. Implantation is an inefficient process. So it's not an efficient process. It does not go in favor of the mother. All right. So you can understand the basic implantation rate to a maximum degree is 30%, 30 to 40%. That is, like now it's reducing gradually because of a worsening lifestyle and diet pattern. Okay. So implantation rate failure in ART cases is further higher, beyond 40 to 60%. Now, why did we dive into this complex subject is that you cannot swim for new horizons until you have courage to lose sight of the shore. So you have to think in lines of reproductive immunology to help your patients with a minimal expenditure on their side, right? So are repeated miscarriages or recurrent IVF failures two sides of the same coin? Yes, of course, isn't it? So basically, one very important thing which I wanted to bring to your notice, because so many of you are there, is that don't think that immunology is for IVF. Please don't have that misconception in your mind. Okay. So what I have done in my 7-8 years of clinical practice, you can use immunological modalities for your natural conception cycles as well. Isn't it? So don't parallel it with IVF cycles. But of course, the cause for losing a natural pregnancy and an IVF pregnancy remains the same. Okay. So don't think that only for IVF patients I'll be, making them have more expenditure in the lines of immunomodulatory therapies. You will be surprised to see at nominal cost you can use immunomodulatory therapies, because we have one full session on passive and active modalities of immunomodulation. I'll tell you, and you'll be surprised. Very known molecules, very low dose for a very short period can help you with continuation of the pregnancy. Okay. So we have read long back when since we were children that you reap what you sow. But this is very, very sad that this is a big question in case of recurrent pregnancy loss and immunological factors. Okay, so this doesn't happen for immunological causes. You are not able to definitely tell the patient this is a problem with you. What happens often in counseling sessions is that the couple, they are very, very dejected. They are depressed in all means, financially, emotionally. They are, completely very much depressed. And they tell you, you're using this new modality, ma'am. Are you sure? Is there guarantee? So you don't say that there is guarantee, but you say this is the best thing we can do for a case where we do not have any definite cause. Okay. So we'll just have to keep trying therapies and help our patients. Okay, so I've told you how do you document a clinical pregnancy. If a gestational sac can be seen on ultrasound, clinically successful implantation is considered to have occurred and beta HCG is detectable. Then what do you mean by implantation failure? When there is no evidence of implantation or HCG cannot be detected, or HCG is detectable but there is no gestational sac on ultrasound. So either of this, okay, that is an implantation failure, right? I think this we'll skip, but just remember that it is defined as in case of IVF only. This is not for natural cycles. So good quality embryos, at least 4, transferred over 3 or more fresh or frozen embryo cycles for a woman who is under 40 years of age. So this is the definition for a recurrent implantation failure in cases of IVF cycles. Okay. So I just wanted to put this slide to give you a concept that, okay, implantation failure and recurrent IVF failures, very early IVF failures are the same, right? Now, how do we define? I've told you from the first slide that this condition you cannot define as well. There is confusion from the definition, okay? But what are the major criteria which we can use for defining this condition easily are number of unsuccessful ART treatment cycles, number of embryos transferred, and a combination of both factors. This is again IVF purview. It's not for natural conception, right? But sadly, there is no existing evidence-based guidelines focusing on immunological factors of idiopathic RIF. So in cases where you're not able to explain a cause, there is no clear-cut guidelines as to which guidelines can help us with working on the therapeutic modalities, okay? So you will see the last ESHRE good practice recommendations on RIF. They have clearly told that it is so common that it is considered as a secondary phenomenon of ART. Okay, so it is so common. Don't be surprised with biochemical pregnancies or recurrent IVF failures happening for a case of IVF. Okay, they have clearly written this. Now, this is again a very important slide. You can see the pregnancy loss iceberg. Okay, so see, for a natural pregnancy, these are spontaneous conceptions wherein you can see the live birth rate is 30%, and for IVF cycles it is 20 or 25%. So the preclinical or pre-implantation pregnancy losses are still much more for IVF conception. Can you see the base of the pyramid? Okay, so we have to be very, very careful for spontaneous as well as for IVF pregnancies. But remember, if you have 5 consecutive euploid embryo transfers, still there is implantation failure. It is not a true recurrent implantation failure. There is some problem other in, that's not an immunological cause. It's not a recurrent, it's not a recurrent implantation failure, but there is no definite cause because you have transferred euploid embryos. Okay, you have done a PGT for the embryos. You have confirmed that the embryos are euploid. Still you are having a recurrent implantation failure, means you have to think in line of immunology. So this is a very recent meta-analysis of 2024. So these are cases where you don't need to think further. You guarantee that this is a case of immunological cause for the implantation failure. Okay. So unexplained cause, I've told you this. Unexplained means immunological, where you cannot find. See, you will tell me, suppose you register for the course and you have you are present in the lecture for diagnostic modalities for immunological cause. There you can ask me, ma'am, should we diagnose with so many tests to ascertain that immunology is the reason for implantation failure? I'll tell you no. That's just for theoretical purpose. You will be surprised, saddened to know that the test of immunological profile, that will cost an additional 60,000-70,000 to the patient. Do you think we are doing justice to the patient? Where we can spend 2,000 and do some passive immunomodulatory mechanisms. It's like testing vitamin D and then giving therapy, or giving therapy directly without testing vitamin D. Okay, because you're not doing harm to the patient, right? Then I move on to implantation. Any doubts till now? Just write in the chat box, please. And give me just 1 minute. I'll take a short break, just 1 minute. You can write any questions in the chat box also. And this is a very, very complex part, implantation. Don't get confused by the pictures, very complicated pictures. I'll tell you only what is required. So be very attentive, and details we can take in the course. Okay. Okay. So I can see no doubts. All right. So what is implantation? If you ask me to define implantation, I'll tell you war in times of love. So a pregnancy is a result of love making, and then there is immense war. There is a huge war at the decidual level between the endometrium and the embryo. Okay. So there is a very, very beautiful paper by Dr. Deepak Modi from NIRRH. So I always follow that paper. I've given a screenshot of that paper also. That is defined as embryo implantation war in times of love. I'll just show you that picture. This is the paper. Okay, so it's freely available in the net to download and go through. You can go through before you're registering for the course. Okay, I think there is one doubt. Okay, please note down your doubt. I'll take it at the end because I've moved on to the next section. I think helper T cell 1 and helper T cell 2. I'll tell you about that. No problem. Okay, so embryo implantation, war in times of love. So few slides may look confusing, but don't go with that. I'll just tell you what is required. Very, very complicated, very complicated. Like implantation, when I went through, it took me 15 days to understand the basics. It's so complicated. But this paper is a very, very good paper which makes things simple. And most of the things I've taken from that paper only. So I'll tell you the 4 steps of implantation. Just give me 1 second. Okay, so the 4 steps, 4 steps of implantation will be, first is hatching. You can see the embryo coming out of the zona. Then there is apposition. This embryo has some L-selectin molecules, and the L-selectin receptors are present on the decidua. And then there is adhesion, wherein the endometrial pinopods adhere to the embryo. So that is attachment. That is, apposition is just touching. Adhesion is getting firmly attached. Okay, and invasion is permeating into the decidua. So these are the 4 steps of implantation: hatching out of the zona, apposition, that is just abutting with the endometrium, adhesion, that is getting attached to the getting firmly attached to the endometrium, and then invading into the endometrium. Okay. So I'll just read out this slide. It was very interesting. The bond between the mother and the child is commonly seen as one of the strongest connections in nature, and extended intrauterine retention of the fetus is regarded as the highest form of self-kill by the mother. So the mother compromises a lot on her immune system when she carries the fetus for the 9 months. Yet, pregnancy has many aspects of a battle. The uterus forces the embryo to prove itself inadequate. So the purpose of the embryo, the uterus, it always forces the
पानी नहीं है
uterus forces.
वो
Please
कहाँ है
mute
महिला
all of you. Please mute yourself.
ये दो बोतल का पानी है क्या ये 2 चम्मच डाली एक आधे 2 छोटे चम्मच बताएगा पूरी नहीं पड़ी आधी आधी चम्मच ये ठीक है ये चम्मच 2 डालने से बहुत गाढ़ा गिलास वाला पानी वाला नहीं वो तो ठीक है तुम दिमाग कम लगाया करो तुमने 2 चम्मच ज्यादा 2 ही चम्मच डाला था वो उन्होंने 1.5 किलो आमी का इतना तो बना के दिया है
Dr. Archana, kindly mute your video.
इनके पास दिमाग है नहीं दिमाग अपना लगाती है बस गेहूं आ गया चलो बढ़िया राम कुमार ने कल पैसे भी डाल दिए थे 10,000 रुपये
I'm there. Hello?
आज ही वो सर ने पंजाब नेशनल
कर दिया मैंने म्यूट. Dr. Lipika, you are muted. You are muted, Dr. Lipika, you are muted.
Sorry. Okay. Am I audible now, sir?
You are very clear now.
Okay. So, the paradox is that the uterus wants to reject the embryo and the embryo wants to fight the battle and get implanted. Okay. So, therefore, that is the paradox. The endometrium is refractory. See, the uterus is meant for conception. But paradoxically, the uterus is, like refractory to embryo implantation throughout the menstrual cycle, except for a narrow window, which is called the window of implantation. All right. So, we'll just try to understand the plot of this battle. I'll tell you in a very simplified manner. Try to understand that the endometrial decidua, the pregnant endometrium, which is called the decidua, that forms a wall, like a great wall of China, and the embryo is like a Trojan horse, a war horse, which is trying to shoot fires at the endometrium to make one part of the endometrium weakened so that it can get implanted in that area. I hope I'm clear. So this is the basic concept, that the endometrium behaves as a strong wall, as a guarded fortress. Okay, consider a wall of a jail, prison or something, and the embryo is constantly shooting at the endometrium with some extracellular vesicles which have lysosomal enzymes to degrade that endometrium, and then it forcibly gets implanted. So only if that is the reason, I think sir will also agree, that's the reason a competent euploid embryo is very much potent to get itself implanted. All right. So that's the reason we try to test the ploidy of the embryo after recurrent miscarriages or after recurrent implantation failures, because our embryo has to be very much potent to get itself implanted into the decidua. So this I've told you, there is a narrow window of receptivity, and I think I should not be going into this. So just understand the receptive endometrium is actually a weakened tissue. I'll show you an animated video, a short, animation kind of slide where you'll understand. The embryo shoots lysosomal lines towards the endometrium. That part of the endometrium gets weakened and the embryo gets implanted there. Okay. So that's all you need to understand. These are the steps. I don't think you need the details. You can go through the paper. I've taken these steps from that paper only. Very, very good paper. So just try to understand that only this small part of the menstrual cycle is the receptive part, right? Now, these are the bullets, the Trojan, the war horses. They release these extracellular vesicles. Can you see? So what happens is the embryo fires the red ones and the green ones. They are basically the embryo and the endometrium derived extracellular vesicles. What do these vesicles have? They have lysosomal enzymes to dissolve the endometrium in that part, right? So this is how simple how simply I can explain it, but it's very, very complex. There are n number of extracellular vesicles which need to be discussed. Every vesicle has different enzymes in that, but we'll go very simplified because we don't need details of that. Okay. And then you can see that the endometrium thins out in certain area, and then there is breaking of the endometrium and the embryo penetrates that region which is weakened, that endometrium, it invades. Okay. So this is a war horse. That was what I was trying to show you. And you can see the lysosomal enzymes being fired towards the decidua. Okay. The animated video will make things clear. So just have a look on this. Okay, so this is the embryo. This is the endometrium, which is a pregnant endometrium or decidua. What happens is this embryo starts firing bullets, which is the extracellular vesicles containing the lysosomal enzymes. It weakens this part of the endometrium and then the embryo implants itself. Okay. Now, the implantation process is always anterior-posterior stretching of the embryo. Okay. So this was what I was trying to show. The anterior-posterior stretching, the embryo stretches itself when it implants. Okay. So there is an anterior-posterior stretching of the endometrium, the embryo. This was what I was showing you. And there, this is the breaking of the wall. This picture is probably the most important and summarized picture for implantation. You can see the embryo here. The blue molecules are the L-selectin molecules, which is the adhesion molecule. These blue ligands on the endometrium are the L-selectin ligands, and the green ones are the pinopodes. So this is how the embryo is becoming adherent to the endometrium, right? And you can see these are the dendritic cells and macrophages I was talking about. So these are the antigen presenting cells. Now coming to immunology of pregnancy, I'll purposefully skip some slides, but this first left figure is the most important of all. Okay, I thought there is some question. Any questions on implantation? I think I've made it simple. You can again go through the recording once again. Okay, so immunology of pregnancy, just remember, see, I've told you that the embryo needs to breach the endometrium to get itself implanted, isn't it? So there has to be an injury. If there is no injury, no inflammation in the very early part of the pregnancy, the embryo is not going to implant. So for very early first trimester, there has to be implantation, right? Again, in the later part of the implantation phase, there has to be anti-inflammation, because too much of inflammation will reject the pregnancy, right? So in the first and the second trimester, there has to be anti-inflammatory cytokines so that the pregnancy can continue. And again, in the third part, there has to be, end of the third trimester, there has to be certain degree of inflammation so that there is onset of labor. Okay, so this is what I have focused here. According to trimesters, there will be inflammation or anti-inflammation. So don't be confused. Just try to understand that it is a very thin line of balance, very delicate balance between inflammation and anti-inflammation. Okay. So Sir Peter Medawar, I should not be talking on this topic without mentioning Sir's name. He's a Nobel laureate and father of reproductive immunology. He was the first person to question the immunological aspect of pregnancy. How does a pregnant mother manage to nourish within herself for many weeks and months a fetus which is antigenically a foreign body? This is surprising. You cannot just take anybody's kidney and transplant it into a patient. Obviously, the kidney will be rejected. And you know that most of the marriages are not consanguineous. So the husband and wife are not related to each other. So it's kind of an organ transplant which is happening in pregnancy. Still the mother continues the pregnancy till 9 months. How does that happen? Okay. So this is pregnancy is a tolerant immunologic profile. So the pregnancy is always a state wherein the mother is in a tendency to accept the pregnancy no matter what. She compromises on her immunity, but still she believes in, like accepting the pregnancy and continuing it till term. Okay. So just remember this. I was telling you about immunological balance because, when I talk about immunomodulation, many places you'll hear me telling that inflammation is required. Some places you'll hear me telling anti-inflammation is required. That will confuse you. So just remember, everything of immunology works on yin-yang therapy, yin-yang theory. So what is that? The yang side is immunological tolerance to self-antigens. So just imagine that when the mother is pregnant, she's also going to have bacterial viral infections also. So if her immunity is too much suppressed, she'll catch hold of cold, cough, bacterial infections, loose motion, vomiting and all of that. So her immune system has to be balanced in a state where she'll not reject her pregnancy, yet she has a fighting capacity to fight for her own body, right? So that is immunological tolerance to self-antigens, and the other side is immunological destruction of invading antigens. So she has to identify which are self cells. Even the pregnancy, she has to identify that the pregnancy has 50% of her genes and 50% of the male partner's gene. Okay. So that, she doesn't, what happens is, see, there are two aspects of immune recognition and immune tolerance. The first step is that the mother has to recognize the pregnancy that this is my self cell and I should not be reacting against them. So one is allo recognition, one is immune tolerance. That is how immunology works. Okay. So this is again the yin-yang theory, wherein you can see one side is inflammation, one side is anti-inflammation. See, have a look on the right side figure. See, I've told you regulatory T cells are immunosuppressive cells. So there is little bit of it, it reduces too much of inflammation. Therefore, the pregnancy will continue. So you can see there is immune tolerance and normal pregnancy will continue. There, the other side, there is too much of helper T cell 1 activity. I've told you 1 is for inflammation. I looks like 1. So helper T cell 1 cytokines, when there is too much of these, the pregnancy will land up in miscarriage. Okay. This I've again told you. So this is a very, very thin line of balance. Too much of inflammation will cause miscarriage. Too less of inflammation will cause miscarriage. So you have to balance things. Okay. I think I will just move on to this slide. This is very, very important in every word of it. Pregnancy is nature's miracle. This is apparent when you look at the immunological aspects of pregnancy. A pregnancy has 50% genetic material from the father and 50% from the mother. The paternal part of the fetus carries with it paternal antigens. These antigens are totally foreign to the mother's immune system, right? So logically speaking, the mother's immune system should build an immunological response against the fetus, leading to rejection of the fetus because it's kind of an organ transplant. Thus, the fetus is a semi-allograft. So 50% is from herself, 50% is from outside, from the male partner. The fetus survives and grows into a healthy baby despite this. Okay, this is the paradox of pregnancy, and it has always been a problem for reproductive immunologists. Okay, so this is one slide. I always 1-2 slides, subsequent slides I'll read out because it's so important. Okay, fetus is a semi-allograft. The embryo and gestational tissues express foreign antigens derived from the different mother and father chromosomes, as the fetus gets 50% of the MHC genes from a genetically non-identical father. It's not a consanguineous marriage. The fetus is termed as a semi-allograft, right? So this is a paradox of pregnancy. In just this next slide, you will understand, despite being a semi-allograft, why the pregnancy continues. So this is the answer, right? Amongst the entire course, I think this will be the most important slide. The immunological interaction between the fetus and the mother is a paradoxical communication that is regulated by a fetal antigen presentation or recognition of the fetal antigens and reaction to these antigens by the mother's immune system. Is it very clear? So the mother needs to recognize that this is a fetal antigen, but I don't consider it as foreign. I consider it as self. Am I clear? This is the major thing which you need to understand. So the mother, see, you put 10 bacteria in the mother's immune system will react. But how come it's not reacting to the fetal antigen? So the mother recognizes the fetus as self, and then it suppresses the reaction of the immune system to the fetus. This is the reason why the pregnancy continues. Am I clear? Can somebody please write a yes in the chat box, because this is the entire basis of this course. Okay, am I clear? Any questions on this? So the first thing is immune recognition of the fetal antigens. The second is immune tolerance, that is no reaction from the mother's side. Okay, so this is how the pregnancy will continue. All right, thank you so much. There have been significant advances in understanding of abnormalities of the maternal fetal immunologic relationship at the placental bed. If you remember, I had shown you a figure where the mother's hand and the fetal hand was there. So that is the placental bed where all of this is happening. Moreover, immunological recognition of pregnancy and inadequate response or immune tolerance. So this immune suppression is required for continuation of pregnancy. The mother should recognize yet not react. So that is how the pregnancy will continue. Okay. Successful pregnancy has been considered as a biological example of semi-allogenic graft acceptance. So it is a semi-allogenic graft. So I hope all of you are clear what is alloimmune and what is autoimmune. Here we are not, although this is a course on immunology, we are not talking about autoimmune conditions. All right. In, I think, one of the last courses, one doctor had asked me the same question. So we are not talking about autoimmune like SLE, rheumatoid arthritis in pregnancy. We are not talking about that, or autoimmune thyroid antibodies. We are not talking on that. We are talking on something which is alloimmune, not autoimmune for the mother. Okay. So successful pregnancy has been considered as a biological example of a semi-allograft acceptance in which the semi-allogenic fetus is protected from the immune attack of the mother. Right? I think I'll skip many slides, but just remember these are the, okay, I'll go through this later on. So these are few of the possible therapies, like theories on based on which the pregnancy continues. Very, very relevant theories. I'll share some literature regarding this also. I've just recently written a handbook on reproductive immunology. If possible, I'll share the pictures of these theories. You can go through, okay? We'll not go into details. And just remember the sperm, the seminal plasma, all the circulating hormones, especially progesterone, cytokines released during ovulation, fertilization, embryo, as well as fallopian tube. All of these factors also contribute to the continuation of the pregnancy. Okay, so this is very paradoxical, but every step the pregnancy is being protected. All right, I'll just mention one very important hormone, progesterone. Do not forget this. This is progestational hormone. You'll be surprised to know that synthetic progesterones like dydrogesterone, they have strong immunomodulatory properties. How does this act? Progesterone can induce immunosuppression at the decidual level. So it reduces too much of inflammation by releasing PIBF. This is one abbreviation which you have to remember. Progesterone induced blocking factor. Okay, so progesterone and HCG, both of this is very important. They help in release of PIBF, and that helps in suppression of inflammation and immune activity continuing pregnancy. Okay, I'll show you a flowchart. This is, again, you can take a picture with your phone. So this is a very nice, like a weighing scale kind of thing where you're seeing inflammatory and anti-inflammatory responses. If you just look at the right side, have a look. You can see helper T cell 2 antibodies. I've told you they are anti-inflammatory. Okay. And helper T cell 1 on the left side, they are inflammatory. Right. So you can see the weighing scale, such delicate balance is required. So can you imagine a pregnancy which is terminating in live birth? How grateful should we be to Almighty? Because this is a very, very thin line of balance. You cannot balance all the cytokines running in the mother's blood. So this is a very, very thin line of balance. Now, just few concluding slides. I'll give you a picture as to what happens in implantation failure. Any questions on immunology of a normal pregnancy? Any questions? Or you can just write it's clear or not. I'll go on to this last segment. Any questions? Should I move further? Can someone please write in the chat box or just tell me, unmute yourself and tell? Because it's important actually. Immunology of pregnancy is important and complex. I hope I was able to give you a clear picture of that. I move on to the immunology. I think nobody is replying, but I'll move on. Immunology of RIF. Okay, so basically you can see from this first picture itself that if regulatory cells are there, appropriately activated uterine NK cells. If you remember, I told you that uterine NK cells will protect the pregnancy, right? Okay. I'll tell you. This is a big, big question. I was telling you, that the question on immunological tests will come up. I'll tell you regarding that. Not cover that part. This is just an introductory talk, so I'll cover that. So you can see the left side, regulatory T cells, appropriately activated uterine NK cells. Remember, macrophage is one cell I had mentioned from the myeloid lineage. That is M1 and M2. Okay. So remember, M2 is anti-inflammatory and M1 is inflammatory. Okay. And tolerogenic dendritic cells. So if you have all the supporting cells which are immunomodulating, immunosuppressing, and then continuing, the pregnancy will continue. Okay. You have too much of inflammatory cells and pro-inflammatory cytokines, there will be implantation failure. So this is the basic thing. Okay. So I think I've told you all of this. I'll go straight to the last 4 flowcharts. Be very, very attentive because this is everything about the entire talk. Okay. So you see this is an embryo protective immunomodulation. First have a look at the flowchart. I'll tell you. Can you see the decidua and the trophoblast? Okay. There is allorecognition. The mother has identified this is a fetal antigen. All right. Now what happens from the decidua and the peripheral blood? There are regulatory T cell which are released, which are activated. Okay. And helper T cell 2 response. Okay. So what happens? I've told you 2 is anti-inflammatory, right? So anti-inflammatory cytokines are released. There is a facilitation reaction. See, don't be confused at all. There is production of blocking antibodies. Remember, these blocking antibodies are preventing the mother from reacting to that fetus. I hope I'm very clear. So we need blocking antibodies. For example, I've told you progesterone induced blocking factor. That is again a blocking antibody. So you need blocking antibodies to protect the embryo so that the mother identifies that it's the fetal antigen, but it will not react against that. Okay. So blocking antibodies are produced and there is protection of pregnancy. From the other side, you see trophoblast release HCG. Progesterone comes from there. PIBF is produced by progesterone. Regulatory T cells are acting. Again, local immunosuppression is happening. So we have a protection of pregnancy. Right? Now, what happens in rejection then? Just have a look. See, there is failure of allorecognition. There is no production of helper T cell 2 cytokines. There is production of helper T cell 17 cytokines. I've told you 1 is inflammatory, 17 is inflammatory. 2 is anti-inflammatory and regulatory T cells are anti-inflammatory. So there is no facilitation reaction. There is no production of blocking antibodies. Here also the trophoblast is not able to secrete HCG. There is no progesterone due to some reason. There is no production of PIBF. Therefore, there is no local immunosuppression and therefore the pregnancy aborts. Right? This I've shown you. You can again take a picture. Everything has been told already, like helper T cell 1, 2, what happens, why the pregnancy is protected or rejected. You can take a picture of this. These 4 photos are, summary again, explaining everything. And this is one slide which I want you to be very attentive. See, T lymphocytes, I've been telling for the last 1 hour about T lymphocytes. I've told you there are 2 types basically, CD8, CD4, T regulatory cell and Th17. Okay, so these are the 4 cells which I've told you. Helper T cell 1 is inflammatory, 2 is anti-inflammatory, 17 is pro-inflammatory, regulatory cells are anti-inflammatory. So just have this flowchart in your mind. Okay. Remember one very important thing, that differentiation of helper T cell 1 and 2 is irreversible. You cannot do anything about it. Okay. But helper T cell 17 and regulatory T cell, they are interconvertible. So if you find that a mother is losing pregnancies, subsequent pregnancies, you can do immunomodulation to convert more of helper T cells to regulatory T cell. Am I clear? So this is where the therapeutic modalities of immunomodulation comes into play. That was what I wanted to print in your mind. Like, this is interconvertible. Okay. So you can use immunomodulatory therapies. We have one full session. There are so many molecules which we didn't recognize their immunomodulatory properties, but now we have a clear idea about that. So there is, what is LIT? It is lymphocyte immunization therapy. We have an entire segment on that. Okay, so these are the 2 methods in which you can interconvert these cells so that the pregnancy continues. Okay, this is again a very, very important slide. Either you have a picture or go through this slide once again, because I've put all the immunosuppressors on one side and immune activators on one side. You know, this makes things very easy. Okay. So knowledge is not power, it's only potential. So whatever you have learned today, that is only gaining potential. Applying that knowledge is power. Understanding why and when to apply the knowledge is wisdom. Just because we know so much of immunology is not, going to try immunological therapies in all your patients. Okay, so you have to identify cases where you are going to use your this knowledge of immunology and your immunomodulatory therapy. So again, I end with the same slide. No doctor has ever healed anyone of anything in the history of mankind. The human immune system heals, and that's the only thing that heals. All right. Thank you very much for your patient hearing for this complicated subject. Thank you for staying till the end.
Thank you, Dr. Lepika. Indeed, a wonderful talk, as always. And there are some questions I would like to, Dr. Mashood is asking, when is it appropriate to run an immunological test when no other factor identified and more than 3 RPL at about 7 weeks?
Yes, sir. That is again an entire investigation as a lecture. So, like I've told you already, things are not like so. Immunological tests, like I was telling you, for vitamin D, the test will cause you much more than the therapy. So, I will tell you 1, 2 very, very important tests which you will do for where you suspect immunological causes. Otherwise, there is a panel of tests. There are dedicated setups for reproductive immunology by Dr. Mohan Raut, Mugdha Raut. They have multiple centers where patients have, paying capacity, and they can spend an additional 60-70,000 for testing their immunological errors, apart from spending for multiple IVF cycles. So that is where you can do the panel of tests. Definitely it carries value. But for my setup in Eastern India, where you consider the cost factor, I'll tell you 1, 2 tests which are very important, and then you can go for. Or you can simply go for passive immunomodulatory therapies where you don't need to test anything, where you're not finding any obvious cause. Go for some simple molecules which is not going to harm the patient in any way.
Dr. Lipika, there's another question. The immunomodulation with PBC will be intrauterine or intradermic?
So please repeat the question.
The immunomodulation with PBC will be intrauterine or intradermic? Intradermal?
Both works. Both works. Okay. Just like, GM-CSF or GCSF endocrine injections, whatever we can do, some believe in intrauterine infusions and some believe. So am I visible? Actually, somewhat my camera is gone out of.
No, everything is fine. You're visible and this is clear. Yeah.
Okay, sir. So you can use it both ways. Sometimes what you do is the ampular vial, whatever it has, like whatever is the total amount, what you can do is half you can infuse it intrauterine and half you can give it subcut or intradermal.
Okay.
We'll discuss all of that.
Was the immunomodulation preferred in chronic endometriosis?
Chronic endometriosis is not the right term, I suppose.
Metritis, spelling
Endometritis,
endometritis.
yeah.
Yeah.
So endometritis, that's again a huge chapter. We used to cover this topic, we took reproductive immunology, the first edition. So endometritis is not, see, definitely there is a hell lot of immunology working, and there is a lot of error of immunological aspects in endometritis. So that is a huge topic. But yes, because you prophylactically take or your histopathology shows some definite, evidence of endometritis, or you have some immunohistochemistry proof of having endometritis, like certain markers are there, CD138, BCL6 and all. Certain labs, when you test the immunological profiles from the endometrial biopsy, they will mention categorically BCL6 or CD138 and the amount of that, whether it's strongly positive or a, yes, those cases you can use immunomodulators. There is no particular route of therapy. You can use oral, intrauterine, whatever, depending on what therapy you are using. In case you're using a oral molecule, you can definitely go for, in chronic endometritis. A simple, I'll just list 1-2 immunomodulators because there are so many questions coming up. So HCQS is one immunomodulator. A low dose of methylprednisolone, which is a very, less potent steroid. It doesn't cause any side effects associated commonly with steroids. So you can use methylprednisolone, very, very cheap, 30 rupees for 10 tablets, it's that cheap. HCQS we've heard of in COVID times. So that is again a potent immunomodulator. Dihydrogesterone is an immunomodulator. IVIG is an immunomodulator. Just 700 rupees or say 500 to 700 rupees. So I don't think that is very costly. You can use all of the immunomodulators. I'll discuss individually in the therapeutic modalities. We have a segment on immunomodulatory therapies, passive and active. Just remember as of now that all the other therapies are under passive. LIT is only one single available active immunomodulatory therapy. I'll tell you, it's just like passive vaccination, vaccinating with antibodies and vaccinating with the live attenuated virus. It's kind of that. Okay.
So if you have any more questions, you can ask live, you can unmute and you can ask your questions.
Mild immunomodulation, I've never heard of. There is no such term as mild immunomodulation. Immunomodulation, either you do or you don't do. There is no mild because see, maybe if you have read it somewhere, this term, it might mean simple giving some passive immunomodulatory therapies. That's what I feel.
Yeah, there is so much to it actually. How much can you cover in 1.5 hours? But I think you've done a wonderful job. And I hope that people who are inquisitive should join the course and try to know more because it's a vast science. It's a a huge database which we can't present to you in this 1 hour. These are all demo sessions. They are meant to be more of a priming sessions, and then for knowing the details you have to come to the course, and we'll be happy to help you with whatever little we know. So, any more questions you can ask directly, you can unmute.
I think sir is very true. Sir, whatever sir is telling is very much applicable to this course particularly because a lot of things, you get to understand only by reading textbooks or attending conferences. But immunology is something it's very, very complex. I must confess that I am still learning. There is a lot to learn because there is so much confusion regarding the subject. This is just a demo lecture. So if you register for the course, actually you get to know extensively about, this kind of lecture will again be repeated in the course first lecture. And then you get to know about the diagnostic tests, which you can do, at what cost it happens, and which are the minimum tests you can do. And can you start immunomodulatory therapies without testing the couple? That also I'll tell you. And we'll have a separate segment on LIT as well. It's coming up in a big way. But though it's not that much relevant, I won't say it's not working because I've done many, like at least 2-3 cases wherein all the patients have conceived and they are continuing pregnancy. So I won't say it's a bad thing, but you have to understand the therapy, which patients you should be doing LIT. Again, the conditions you should be understanding. So I would just request, if you're interested for this kind of this course, please register for it because we'll complete the entire thing in 3 sessions. So on 22nd, 25th and 28th. And then we'll have a question session, question answer. You can answer the questions. Anytime you can post your queries.
Yeah, thank you so much, Dr. Lipika, for that wonderful session. I think we'll close the session because even you have some engagements, you told me. So, thank you for taking time off your busy
So
schedule.
somebody has asked any good book to go through before this course. Please go through articles because I have not been able to complete a single book, although I have purchased so many regarding immunology. It's difficult. But what you can do is just go through articles, some relevant articles. I'll immediately share that embryo implantation war in times of love and some relevant papers if I find, so that you can go through those papers. That will be much easier.
Yeah, we can share the articles in the in the
Yes,
demo
sir.
group, and
Yes,
then
sir, I'll do that. I'll
they
do
can
that. Within
utilize.
tomorrow, I'll do that.
Yeah. Thank you so much, Dr. Lipika. Thank you. I'm
Thank you, sir.
ending the
My
session
pleasure.
now. Yeah.
Thank you, sir.
Thank you. Thank you. You will have to end the session since you are the primary host. Yeah.
Okay, sir. I'll do that.